capsular. The open procedure of McLaughlin procedure, transfer of subscapularis tendon into the defect, whereas in knee procedure, the Neer and Foster subsequently described the transfer of subscapularis with lesser tuberosity into the defect and securing it with a screw. Procedures of historic interest are Weber's osteotomy, Putty-Platt procedure, which is not usually done now. Their main disadvantage is the procedure is performed on throwers because it reduces the range of motion, 30 to 35 incidents of developing late OA. Magnuson stack procedure, it is a loss of functional abilities due to significant loss of external rotation, recurrence of instability, injury to nerves and blood vessels, bleeding, infection, and secondary osteoarthritis are the complications. Thank you.
Thanks, Praveen. The idea of giving this talk on the classification of dislocation is mainly to understand the principles, what is happening in the shoulder, which we need to understand. Actually, you started your presentation very well because you explained each and every concept. No need to discuss in detail about the surgical techniques and tips because we are going to discuss each and every surgeries in detail. Okay, so I'm happy with your presentation. That's good. Well, let's finish off the MDI concept and then we'll discuss because this is a very tricky aspect of the shoulder. If we do not understand the pathomechanics in lax shoulder or a patient with MDI or a patient with voluntary or involuntary dislocations, we will be treating them wrong. So let's finish off the MDI concept and then come to the discussion.
Yes, sir.
Good morning, sir. Is my screen visible, sir?
Yes, Jason.
Today I'll be presenting about multidirectional instability. So it was first described by Neer and Foster as an instability of the shoulder in more than one direction without history of trauma or following a very minimal trauma. Although different definitions were tried to be made for this, there is no consensus for this pathology in literature, and hence definition by Neer and Foster holds good till date. 3 different instability forms were reported according to various on dislocation. That is anterior inferior dislocation accompanying posterior subluxation, or posterior inferior dislocation accompanying anterior subluxation, and global dislocation. Madsen et al. Tried to label shoulder instability in 2 groups, which is Stoops and Ambry, which was discussed by Praveen. But the distinctions between the instability and laxity, or between microtrauma and macrotrauma, are not made in this classification, and hence it is insufficient in evaluation of MDI. So distinction between laxity and instability becomes very important. Laxity can be defined as an increase in physiological range of motion and increase in joint elasticity. And it is usually an asymptomatic condition considered physiological and maybe one of the predisposing factors causing instability. On the contrary, instability is symptomatic pathological condition and may develop after repetitive microtrauma or a single event of major trauma. Gerber and Nifeller tried to comprehensively classify under the term dynamic instability, and they classified as chronic lock dislocation, unidirectional, as the name says, it is one direction, multidirectional, and instability with voluntary reduction. So unidirectional is again classified into the presence of hyperlaxity and without hyperlaxity. Without hyperlaxity, the thing which we have to note down is there is frequent capsulolabral lesions associated with, and in cases with hyperlaxity, it is not the labral issue, it is actually the patulous capsular tissue. And coming to biomechanics and pathoanatomy, so it is the glenohumeral joint stability is between the a balance between the static and dynamic stabilizers. In static stabilizers between glenoid version and concavity, labrum, the glenoid ligaments, dynamic being the muscles, rotator cuff, and proprioceptive and neuromuscular control. So in cases where these stabilizers are defective, stability can usually be maintained by the compensation of the other. So the whole principle of treatment in multidirectional instability is dependent on increasing the stability of the dynamic stabilizers. And the patulous capsular tissue with loose and redundant inflamed capsule will cause the voluminous increase in the joint, and are characteristic findings in MDI, which is present in almost all the cases. So the coordination is ensured by the protection of concavity compression mechanism, as explained in the previous talk, which is usually provided by rotator cuff during motion. And also it is also dependent on correct positioning and version of scapula, and therefore glenoid, with the effect of all the muscles, the scapular muscles, scapulothoracic, with neuromuscular proprioception control. The other two important factors are altered muscle control and altered proprioception and center friction. So altered muscle control is the inability of the passive structures to optimally limit and control motion of the joint. And this could be due to pain, when the pain actually decreases the motor discharge and reduces voluntary contractions, leading to the altered muscle control. So excessive laxity, which is the virtue of MDI, causes microtrauma, which may damage the neural receptors in the joint, disrupting afferent signaling to the CNS, and hence efferent signal is also disrupted, affecting the neuromuscular control of scapular and humeral muscles. Coming to history, patient may report multiple episodes of dislocation or subluxation and might be associated with non-focal shoulder pain to recurrent shoulder dislocations. So it can vary, and features might be anterior instability, where the apprehension is seen during abduction and external or overhead activities. Posterior instability is experienced where the arm is in forward flexion and interrotation, and this position is seen while pushing the door, driving, trimming the t-shirt, or while doing push-ups. Inferior instability is experienced when instability episodes are seen while carrying the heavy bags. Patients who demonstrate these positions that lead to instability but attempt to avoid will have a very good outcomes after surgery. And this group should be differentiated from voluntary willful dislocators who may respond poorly to the surgery. Another important thing is the scapular dyskinesia. Scapular motion should be observed in every patient evaluated for instability. And altered mechanics have been shown to occur at higher rates in MDI compared to the asymptomatic ones. Assessment of strength and range of motion is also important, and it's compared with the contralateral unaffected shoulder. And especially this becomes important in patients with generalized laxity. Examination maneuvers are the load and shift test, both anterior and posterior, process of sulcus sign, hyperadduction maneuver, the apprehension test, relocation test, and jerk test. Poor scapular positioning through the range of motion and altered muscle patterning are the characteristic features of non-traumatic MDI. So active forward flexion and abduction range of motion, which we usually follow here, is done to determine the presence of scapular dyskinesia and aberrant humeral translations. So when the patient is subjected to forward flexion and abduction, scapular dyskinesia is picked up. So, and any immediate improvement with manual assistance is likely to confirm the presence of these characteristics. And this is a positive indicator that the patient is going to improve with the exercise. Imaging, conventional radiograph to assess for major glenoid humeral defects. CT, MRI remains the gold standard because it is helpful in assessing capsule ligamentous and the joint capsule redundancy. MRI is shown to be of more diagnostic value than MRI due to its ability to measure the volume of the capsule. This is the crescent sign and the triangular sign characteristically seen in MRA, and it is the contrast between humeral head and the AIGHL, and this triangular sign is between AIGHL and the glenoid on the coronal sections. So presence of these two signs on MRA was up to 90% sensitive and 84% specific in diagnosing MDI. Few other studies have come up determining the increased rotator interval width and joint capsule widening, and they showed that more than 15 mm width and 6 mm depth had more sensitivity and specificity for MDI. So first line, coming to the management, first line of the treatment is rehabilitation in all MDI patient. And as discussed before, we have to strike a balance between the dynamic and static stabilizers, and being the static stabilizers being it can't be affected much. We concentrate upon dynamic stabilizers and also and hence attempting to compensate for static stabilizers. Traditionally, recommended rehabilitation programs mainly focused on the rotator cuff, but with recent understanding of shoulder biomechanics, importance has been given to the excess of deltoid and scapular stabilizers in combination with plyometric and proprioceptive training. So MDI typically have altered scapular kinematics and deficiency in upward scapular rotation. So this is how it is. This is the normal anatomy where the scapula is internally rotated anteriorly for around 30 to 45 degrees. It is anteriorly tipped, that is around 10 to 20 degrees. And this is the most important factor which is affected in MDI. The upward rotation of scapula, which is around 10 to 20 degrees, is deficient. And typically patient have a downward rotation of scapula at rest and lack of upward movement of the scapula through the arm elevation. So this reduces the relative contact area between the glenoid and the humeral head, which contributes to the pathognomonic sulcus sign, which is usually seen at rest in MDI. And this causes altered humeral head translations through the range of motion. And any decrease in this bony congruency between the glenoid and humeral head places additional strain in already lax muscles around the shoulder joint and inhibits that length tension relationship of the rotator cuff, all of which affect the concavity compression mechanism of the humeral head on the glenoid. So conservative being the main modality of treatment, it requires at least 6 months of therapy before considering the surgical treatment. So Watson et al. A study in 2016 created 6-stage program for MDI, which focuses more on functional positioning exercises and improving scapular kinematics. So the basis of this Watson instability program is the effect of correction. So Watson conducted the studies in 2 different parts. One was in 16 and 17 and guided on the rehabilitation program in MDI. So the most important thing is scapular correction. So this is the normal scapula. This is the downward rotation of the scapula, which is seen in MDI. The correction is the correction attained is to elevate, is to restore the upward rotation. So it is restored with the upward rotation of 10 degree and elevation of around 1-2 centimeters with a posterior tilt of 5 degree. So this is the maneuver used. So the hand is actually placed in the axilla and this correction is given. So it is upward rotation, elevation and posterior tilt. In some cases, humeral head correction is also warranted depending upon the instability. If it is posterior, a posterior restraint is given. If it is anterior, anterior restraint is given as shown in the picture. So Watson in 2022, this is the recent article published by Watson et al. They gave corrections for their own study, which was published in 2 parts. And they said that usually what we see here, it is a therapist assisted correction. So they also tried self-actuated scapular correction, and they found out that this group have a faster rate of recovery and greater benefit from the program. So what are those 6 stages? So Stage 1, scapular phase. Scapular phase, we all know what we have discussed till now. It is these findings. And this is done at around 20 degrees of abduction. So patient is instructed to upwardly rotate, elevate, and posteriorly tilt the shoulder at 20 degrees of abduction. So very importantly, in cases of MDI, there is also concurrent neck weakness, and cervical rehabilitation prior to commencing shoulder rehabilitation becomes utmost important. This scapular advantage of this scapular recruitment is it helps in recruiting more upward rotators of scapula compared to the AMBRII side. So it is done at 20 degrees of abduction. This increases the length tension relationship as discussed before. So the second phase is arc of motion phase. The main aim is to regain the humeral head within the glenoid at 0 degrees of elevation. That is the hand by the side of the body. And once this adequate control is obtained, short arc of ER is usually commenced. This is progressed from mid-range to larger arcs of motion, and this is usually concentrated on extension, interrotation, and external of the joint. So this is how it is done. So this band along the humeral head is constant throughout the stages, because this is the resistance to this actual scapular phase. So initially, extension and external rotation are started with against resistance, and internal rotation is usually commenced after extension and external rotation control is obtained, because excessive anterior tilt of the scapula will cause more instability episodes, and the pectoral dominance is also seen if the internal rotation is commenced very early. So this is the second update which they gave. Usually when the patient is able to sustain this stable position of the scapular position, weights are added. So the second update which was given in 22 was they used the one more resistance band to do the same set of exercises. Next is the side lie external rotation with weight is added to gain additional muscle support posteriorly. The main principle of the entire treatment method is to instruct the patient to set the scapula in the correct position. Stage 2 is posterior muscular development. So it aims to develop the posterior musculature. It is done against resistance using the bands, and this prevents posterior humeral translation and prepare for the next stage, which is flexion-based drills. So 3 is flexion plane control in 0 to 40 degrees of elevation. So initially it was by the side of the body. Now it is elevated in the coronal plane to around 0 to 45 degrees and establish a flexion-based control. If the patient has any difficulty here, it is regressed back to the stage 2. Stage 4 is sagittal and coronal plane control in 45 to 90. Initial phase was 0 to 45. Now we are progressing to 45 to 90 degrees. Again, external rotation and extension is done initially, and internal rotation is focused at last. So patient is so this becomes stable in all the stages. This band, which is resisting the actual shoulder position, and external rotation is done, and flexion in 90 degrees of abduction. So it is taken from extension to flexion across the body. So this is done in increased weights. Stage 5 is deltoid function. So it is the most important aspect, and the bent over row at 90 degrees of elevation will activate the posterior deltoid and overhead press the middle deltoid, and short lever lateral raise for the anterior deltoid. The final stage is sports specific and functional stage. The exercises are usually tailored to the needs and the goals of the patient, where the principles being the same: ensuring scapular position and to gain the control of humeral head motion, progressing from shorter arc to the larger arc, and progressing from light to heavier loads. Kinetic chain is also very important. Lower limb chain is commenced early and progress to the upper limb chain and can be and this can be implemented once the shoulder is stable enough to contribute this sequence of movements. Finally, return to sports. The patient should actually pass the strength prior to return to sports and then progress to full competition. And principles ensuring the adequate scapular and abdominal strength to return to high level activity applies to the both the surgical group and the conservative group. And they have significant improvement after 6 weeks of instability program. The importance is only 3 programs is described till now for atraumatic shoulder instability with enough detail to replicate in clinical settings. Of this program, Watson program, has been shown to significantly improve the outcomes of patients in MDA with the MDA in an RCT of Australian New Zealand clinical registry. The other program was a Rockwood instability program. So this has been outweighed by WIP. Coming to surgical treatment, majority of the patient respond well to the rehabilitation, and good results are obtained with the current rehabilitation programs. But patients with the history of trauma or young athletes need surgical intervention due to persistent instability. And the main indication is only for a small limited group of patient in whom the symptoms persist despite the appropriate rehabilitation program. And point to be noted is it is usually avoided in patients with voluntary dislocation and cases of psychiatric pathology. Coming to the first procedure, it is open inferior capsular shift described by Neer. It was the gold standard method until the 1990s when till the arthroscopic repair took over. And the principle is to achieve a reduction in anterior inferior posterior capsular volume by performing application of inferior capsule. This is how we reduce the volume of the capsule. So examinations done under anesthesia, determination of the dominant direction of instability, anterior, posterior, or inferior, and which are positioned delta pectoral approach. Conjoint tendon is exposed, incision between upper and lower, upper 2/3 and lower 1/3 of subscapular, scapular incision along the line. So the inferior capsule is usually sutured first, and the upper flap is taken over the repaired inferior strap and inferior flap and sutured. 3 different types of suturing repair is demonstrated, and T-shaped incision usually taken with T facing towards the humeral has a good reduction in the volume. And hence the amount of capsular shifting is of great importance in order to have a balance between stability, preventing recurrence, and minimize post-operative range of motion. So this procedure usually is performed at 45 degrees of abduction in neutral rotation. And there are so many studies which have been done to support that when inferior capsule shift is combined with Bankert repair, the success of the repair is around 95%. Also, arthroscopic capsular application advantages is it preserves the dynamic stabilizer, the subscapularis, better visualization. It can visualize the intra-articular capsular area changes which are specific to MDA along with the status of the capsule. So diagnostic arthroscopy is done, and the main characteristic thing is the drive-through sign, which is observed in arthroscopy. Once this is the increased space is seen, it is the typical of patulous capsule and needs capsular application. So it is also sometimes it is also important to rule out the humeral side of the pathology causing this patulous capsule. So you have to look out for Hagel lesion also. So it is freshened and anchors placed, and this is after the final repair. So this study found out that the open repair has 50% reduction in volume compared to the arthroscopic, which is around 25%. So this study showed that the amount of volume reduction with respect to stitch and 1 centimeter caused 10% of volume reduction. Another important thing is to have the knowledge of zones of risk for axillary nerve, which is usually it is the branch to teres minor, and it is present in close proximity to the inferior glenoid. And it was reported that external rotation, abduction, and slight traction provide the largest margin between the capsule and the axillary nerve. One more procedure was the rotatory interval closure, again described by Neer and Foster. So here there are two different types of closure. It is either mediolateral or superior inferior. The open procedure is I'll come to that. So this is the arthroscopic image. This is the rotatory interval between subscapularis and the supraspinatus muscle, and pictorial representation. So supraspinatus and subscapularis muscle, and these green, blue, and yellow are the contents of the rotatory interval. This is biceps tendon, coracohumeral ligament, SGHL, and rotatory interval capsule. The same thing seen on MRI. So this is the open method where there is mediolateral application of the superior of the rotatory interval, and orthoscopically how we do is it is closure of this, so approximation of this STHL and MGHL. So the open mediolateral has better results compared to the arthroscopic superior inferior reconstruction. And the disadvantages about this rotatory interval capsule is limitation of external rotation, and the decision is made individually with the patient. And to prevent that, rotatory interval is closed with 30 degrees of external rotation, which causes limitation, which allows us to avoid that complication. The thermal capsulography is actually the shrinkage of the capsule, which can aid with the aid of arthroscopic heat generating probe, not recommended currently. So failed MDA surgery, the main indicator being the persistence of glenohumeral instability, pain, and stiffness. So it is again investigated to rule out any chondral defects or any implant for this pain and stiffness. And postoperative stiffness might be related to prolonged immobilization or aggressive capsular volume reduction due to imperfect surgical technique, and hence a decision has to be made during the capsular application on how much we are going to reduce the volume. So inadequate postoperative rehabilitation and postoperative scapular dyskinesis can also be one of the reasons. And a detailed physical examination is essential to identify the scapular dyskinesis, which can be treated extensively with the conservative management with rehabilitation before considering revision surgery. So take-home message, MDA is a condition that can be challenging for physicians, especially at the diagnosis stage. Conservative management is the first line of treatment for MDA, and Watson Instability program has the current highest level of evidence for effectiveness. So surgical treatment is indicated for patient whose symptoms persist despite appropriate rehabilitation. And finally, the success of this surgical treatment is dependent on understanding the biomechanisms of the entire shoulder joint and the pathoanatomy of the joint instability. Thank you, sir.
Thanks, Chetan. That was quite an extensive discussion about MDI, but a very important topic, because this is where shoulder surgeons tend to falter. So what we need to think is first try to understand what are all the factors which contribute to the shoulder stability. We have the ligamentous structures, we have the bony anatomy, as well as the neurological factors, the proprioception. Now, proprioception is definitely not under our control. Same way, the ligament laxity is also not under our control. But things other than that, say the bony anatomy, yes, if it is altered, we can definitely try to alter the anatomy. Even the ligamentous laxity can be changed, but only in indicated cases. But proprioception, and the most important thing is the intra-articular negative pressure. That's very, very important, plays a crucial role. These things are non-modifiable risk factors. And especially in patients with lax joints, there is definite variation in the intra-articular pressure, so which is not under our control. And hence, thinking about all these, what has been explained in the class, and then analyzing those factors in diagnosing a patient's OPD, is very, very difficult. So let me concise it in such a way that all MDA patients, I divide the patients into two types. One is voluntary dislocators, which is psychological factors. Next one is involuntary dislocators, which is not under their control. So when involuntary dislocators dislocate the joint due to two factors. One, it can be due to anatomical factor, which means the patient has a visible anatomical defect in the form of a Bankart lesion, posterior labral lesion, or glenoid bone loss, or in the presence of excessive glenoid version. These are all the anatomical factors which are responsible for involuntary dislocations. Then another type of involuntary dislocators are due to neurological complications, which may be due to tremors or neuromuscular incoordination and those factors. So all involuntary dislocators with an anatomical lesion need treatment, most commonly in the form of surgeries. If it is other factors like probably scapular disc kinesis or a neurological or muscular imbalance, line of conservative treatment is started. And if the patient does not improve with 3 months of rehabilitation, especially in patients with lax shoulder alone, in the absence of any neurological complications, yes, in that small subset of patients, capsulolabral plication, which is also called as capsulolabroplasty, holds really good. And the other cases, always first line of management is rehabilitation, extensive rehabilitation for 6 months, and then counseling. In case of voluntary dislocators, no matter whatever you do, if in case you do any surgery, you're going to fail. So those are the patients whom you should actually try to avoid. Make sure they do not come to your OPD, because they need a lot of psychological counseling, and the more you counsel them, the better is the prospect for a successful recovery. So never put your knife on those patients, and be careful when you're coming across a patient with a lax shoulder, especially a young patient.
You're done, Shyam?
Sir, yes, sir. Over, sir. Anything to be added?
Okay. Right, and I just was trying to add a few. See, a lot of things are of historical importance, and switching from open to arthroscopy and the failure in arthroscopy, well, ill understood earlier. Now we are much more clear, and since the percentage of failure was unacceptable, all kinds of things were thought of. For example, the interval closure. We used to go all out to do interval closure in patients with sulcus sign. Then we realized that in axial rotation, if it closes, then no need to do anything. And also in the long run, a lot of studies indicated that interval closure is absolutely of not much of an use. So we always, the surgeons have always been looking at an adjuvant procedure to improve the percentage of success. Eventually we have come to remplissage, and the remplissage has become the standard technique along with Bankart repair in selected cases. So the percentage of success is acceptable. So one other thing I would like to mention to you guys, some of them may not know, the radio frequency unit that you see has got a long history, been having downside as well as upside. When we started using radio frequency, it was surgeon's magic wand. Everybody wants to do everything with that. One thing I must admit, the number of multi-directional MDI type of shoulder we hardly ever see. Earlier we used to see quite a bit. I really don't understand how. You don't see them much at all. I don't know whether maybe, the Shah may be seeing all of them. I don't know. And the magic wand of radio frequency, surgeons thought is everything. And the industries pushed a lot of surgeons, sent surgeons all over the world to promote it. And for the MDI, a lot of surgeons just swept it up and down, up and down, up and down, and shrunk it, and felt like magicians, And in the long-term result was total disaster, because in the bargain they cooked all the muscles, subscap, and all the muscles infrasupra, and they resulted in absolute disaster, recurrence of MDI. So then they put an end to this, and surgeons ridiculed this. I still remember on Ahmedabad meeting of IAS, there was a big debate between two surgeons, because one, I don't want to mention the names, one surgeon from UK who was sponsored by one of the companies, one of the companies, and they came and promoted this. The other surgeon from South Africa, went tooth and nail and said, please do not do this. And we are in India, and we already know that the shrinkage by vapor, whatever, doesn't work. I can never forget this. So that came to an end. And so the standard adjoint procedure, now you cannot stop with just Bangkok repair capsular shift of the inferior capsule alone. You have to do the remplissage also. So that's a bit of history. I'm sure the way this vapor and the capsular shrinkage will be reinvented in your time. So at that time, please remember me. Thank you. Is Gopal there?
Yes, I'm here, and
Gopal.
I've used shrinkage and regretted, because we had an avascular necrosis of a humeral head. We had a destroyed glenoid, and we used it sparingly. And I said, this is not for us. And as you well know, David, we also tried it for menisci in the knee joint and paid bitterly for it. Yeah, I don't recommend to the young surgeons to try vapor, because it's nothing but putting the joint inside a microwave and cooking it with no control.
No, we have to have a good memory. I'm sure the
Yes.
present generation of, not even generation of Sham, and somebody will reinvent it. And maybe the year 43, they'll say, oh, that's the answer. Thank you.
Thank you, sir.
I will say good night. It was excellent discussion.
Thank you, Gopal. Good night.
Yeah, and I just got off the phone with Sumant, and I told him, I sent him the link for the last talk, and I'm going to ask Shyam to give me the link so that the residents at Baylor can listen to the talk today, because this is one interesting topic. It really is. Multi-directional.
Yes, sir, we will definitely share it, sir. Sure.
That'd be
Yes.
nice, Gopal. Thank you.
Thank you, Shyam. Thank you so much. I will say good night.
Good night.
And I'm sorry that we lost to Australia. I knew it was coming. Okay, bye-bye.
Bye.
Good morning, sir. Is my screen visible, sir?
Yeah, visible, Sushil.
Good morning, sir. Today I'll be presenting about Modic changes, sir. So, what are Modic changes? These are signal intensity changes of vertebral end plates and subchondral bone, which are often seen in MRI. In 1988, Michael T. Modic, he summarized these changes and classified them into 3 types, and classified them into Modic changes, which later on become as a standard medical term. These are mainly incidental lesions, which are mostly seen associated with spinal degenerative diseases. Coming to the type of Modic changes, there are mainly 3 types. Coming to type 1 Modic change, type 1 Modic change usually presents as a hypo-intense signal in a T1 weighted imaging, a hyper-intense signal in T2 weighted imaging. These type 1 Modic changes actually mean as vertebral body edema and hypervascularity in the end plate region. Type 2 Modic changes, these in the MRI in both in T1 weighted images and T2 weighted images appear as a hyper intense signals. These represent actually a fatty replacement of the red bone marrow in the end plates. And coming to type 3 Modic changes both in T1 weighted images and T2 weighted images show a hypointense signal. So these are these represent a subchondral bone sclerosis in the vertebral end plates, and this is a very rare entity. Miller classified Modic changes into 4 grades. Classified into grade 0 to grade 3, where grade 0 he classified into a no degeneration or normal thing, and grade 1 as Modic changes type 1, and grade 2 Modic changes type 2, and grade 3 as Modic changes type 3. And Vishapto et al. Also classified the Modic changes depending upon the vertebral height involved, where he classified grade 1 as normal, grade 2 as a mild scope of the signal intensity changes, which is less than 25%. Grade 3 is moderate, where the scope of intensity signal change is 25 to less than 50%. And grade 4 is severe, where the scope of signal intensity change was more than 50%. Coming to the mechanisms, there are 2 main theories explaining the mechanism of Modic changes. One is biomechanical. So what biomechanical mechanism states that the end plate and the vertebral bodies are a weak link of the spine. So any changes in the nucleus pulposus leads to increase in the shear forces on the end plates, which results in the microfractures and fissures formation. These microfractures and fissures results in a increased vascularity in that region. So when MRI is taken in the early stages, these represent as a Modic changes type 1. This theory is also supported by the fact that the conversion of Modic changes type 1 to type 2 for fusion and instrumented stabilization further supported the mechanical stress theory. So basically, biomechanical theory states an abnormal load and stress will affect the vertebral end plates and the microenvironment of the adjacent vertebra. This is also confirmed by the histopathological studies and the MRI done. Coming to etiology and risk factors, mainly the etiology is divided into multifactorial etiology is there. So degenerative causes or any instability, genetic trauma or infection, and any autoimmune are the most common etiologies, and risk factor being the degenerative disc disease, which is the most common risk factor. Older age in males also form one of the risk factors. Diabetes mellitus, smoking, obesity and spinal deformities, and people with higher occupational load also carry, this is also one of the common risk factors. Coming to biomechanical theory, biomechanical theory actually states that there is a upregulation of inflammatory mediators in the nucleus pulposus that could result in a local inflammation. This inflammatory reaction is a toxic substance which causes toxic substances which are released by the degenerative disc disease. The most common inflammatory mediators released being the interleukin 6 and interleukin 8 and prostaglandin. These are seen in high concentrations. So because of this, the major origin of pain for low backache, discogenic low backache was postulated. So This theory is further supported by the fact that following an intradiscal steroid injection, there was a short-term efficacy in patients with chronic low backache and predominantly Modic changes type 1. Coming to conversion patterns, there is a interconversion thing happening between the Modic type 0, type 1 or type 2 possibly occurs. This conversion of type 1 to type 2 is most common, and the time span between the different conversions is at least an year. The most common region associated with Modic changes is L5S1 region, and it is much more associated when there is a symptomatic disc herniations. The incidence of new Modic changes during the 3-year follow-up was 6%. The incidence of new Modic changes type 1 was closely related to the previous disc herniations, and it was also higher in patients who had undergone surgery for lumbar disc herniation. So basically, the Modic changes are not different entities, but these represent different stages of the same pathological process. Coming to Modic changes and association between low backache, various studies have been done in the past where they have told that the Modic changes is strongly associated with lumbar back pain. Especially two main studies. One was the Kargje et al. In 2006 done in Denmark, where the number of studies in number of subjects involved were 412. They showed a strong association of Modic changes with low back pain. Similarly, considering the occupation, Kushima et al. In 2007 in Finland, they carried out the same study in a working population of nurses and engineers, where the number of subjects involved were 228, and they also showed that now Modic changes were significantly associated with lumbar back pain, but it doesn't have any association regarding the occupations. Coming to the prevalence and distribution, the prevalence of Modic changes varies from almost 18% to 62% with patients in low back pain. The most common patterns are type 1 and type 2. Most studies have shown that type 2 Modic changes are much common. And the distribution of Modic changes is much more prominent in the lumbar spine, and in the region of L4, L5 and L5S1 were the most common region affected. Even the location of signal changes were more in the anterior 1/3 of the vertebra than in the posterior 2/3 of the vertebra. And the distribution of type 2 was predominant in the superior end plate versus the inferior end plate. Again, continuing, these Modic changes were parallel on both sides of the disc with a vertical depth which varied from 3 to 30 mm. Most of the asymptomatic Modic changes were at a higher level and included the superior end plates of L3 and L4, and which was anteriorly, whereas the symptomatic Modic changes which were appeared at the lower level, where the stresses of the stress forces occur much more in the lower segment. The most common region being the L4, L5 and L5S1 disc areas. In cervical region, the most common region affected were the C5 and C6. Coming to the clinical significance of Modic changes, the occurrence of Modic changes type 1 are the signs of pseudoarthrosis formation by evaluating the segmental spine instability. The Modic changes type 1 tended to show hypermobility and required a fusion surgery. Modic changes was also considered as a risk factor for the recurrent disc herniations after a successful percutaneous endoscopic lumbar discectomy done. These studies actually showed us that any clinical interventions done has an effect on the course of Modic changes. So posterior fusions are done, posterior fusion which are done accelerates the course of Modic changes type 1, probably by correcting the mechanical instability which was present. And dynamic stabilization system is useful to prevent the progression of initial degenerative disc disease of lumbar spine segments after any disc surgery. So after these studies, there was a conclusion that there was once the mechanical conditions any changes in the mechanical conditions of the spinal segments would slow the progression of the modic changes. Disc herniations and modic changes coexist. There is always a possibility of infection should be suspected. Patients with modic changes following discectomy show poor outcome. There was a belief that the pain which was only thought of the origin of the pain was thought of only discogenic, but now the theory has shifted to vertebrogenic. Since the vertebral end plate is rich in neural elements, these are the potential pain generators we can attribute to the chronic low backache in patients with modic changes. Coming to the conservative management in a patients with low backache or disc herniation with the modic changes, they respond very poorly. The theory here is that the presence of hyaline cartilage in a herniated disc results in less chances of resorption and vascular infiltration. A multicentral trial was done where they concluded that there is no role of antibiotics in modic changes, and there was no role of giving bisphosphonates or hyperbaric oxygen for the treatment of modic changes. Wang et al. Did a study to see the fusion rate changes and cage subsidence after transforaminal lumbar interbody fusion, where he concluded that cage subsidence in modic change type 1 and type 2 was higher, but it didn't influence any changes in the fusion rates. So end plate modic changes have no significant influence on the clinical outcome parameters in patients with lumbar spinal stenosis when compared with patients without modic changes. So it is independent of the surgical management which we choose as the surgeon chooses. Infection is also one of the etiology where the theory was there for modic changes. So an infection with a low-grade organism was also implicated. The most common organism implicated is the Propionibacterium acnes. This bacteria is anaerobic, aerotolerant, and non-motile. The non-spore and it's also a non-spore forming and rod-shaped. Propionibacterium acnes can form the biofilms. So the concept of biofilms within the biofilms was postulated by Kosashia, where he stated that the disc is a avascular structure. So when the Propionibacterium gets access to the intervertebral disc, the intervertebral disc acts as a biofilm. Along with that, the Propionibacteria also forms its own biofilm. So coming to differential diagnosis of modic changes, the most common differential is a spinal infection. So the spinal infection should be differentiated from modic changes, where the spinal infection shows paravertebral soft tissue edemas or any epidural mass effects, typically a hyperintense signal on the T2 weighted images. The spinal infection is most commonly confused with the modic change type 1, where the modic change type 1 was a normal or a hypointense signal in a T2 weighted image, and a hypointense in a T1 or a T1 weighted image in the vertebral bodies. The most common sign where there will be erosion of vertebral body and the end plates seen in the spinal infection, and it is also better delineated in a CT scan. The other differential being the Schomerol nodes. Schomerol nodes are a localized defect which is hypointense on T1 weighted images and hyperintense in T2 weighted images. These are localized, well circumcised defects with herniation pits surrounding a wall of hypointense signal in the vertebral body. The next differential would be a spondyloarthropathy. Spondyloarthropathy can be differentiated by the systematic symptoms and clinical signs. along with plain radiographs. The other major differential diagnosis being the metastasis. The main differentiating point in metastasis is the absence of any disk space involvement. So, take-home message is this: Modic changes are dynamic markers of a normal age, and these are related to a degenerative process in a lumbar spine. The Modic changes are strongly associated with a chronic low backache. The natural history and conversions may be affected after any clinical intervention. Knowledge of Modic changes, as we understand, can affect the management. Can affect the surgical management, and much more prospective and randomized clinical trials are required for further management of the Modic changes. Thanks.
Sriram,
Sir,
your comments?
sir, we were discussing the same thing, sir. Modic changes were actually described from 1988, and even after 35 years, there was no clarity of what it is exactly. The basic, I don't know, sir. This is for your opinion.
Yeah. The point is,
It's a personal feeling.
is he a postgraduate of yours or fellow of yours, the presenter?
Srishan is our fellow, sir. Fellow doctor. MJ University last year fellow, who has given the exam.
Oh, yes. I mean, actually, addressing the fellows and other postgraduates, you remember the Netter's picture on degenerative changes of lumbar spine? That was decided on certain radiological pictures earlier. When MRI came in, they re-look into that, and see, the point is radiological changes occur later, and by the time it is identified, you have lost a good time in managing such painful conditions. So this MRI helped us to change our early diagnosis and institution of treatment, and also it also helped us to study the etiology. For the fellow in spine, lumbar spine is your bread and butter. So lumbar spine and cervical spine are identical. Segment which is mobile above the immobile segment. Above the sacral is the lumbar spine, and above the thoracic, especially the upper thoracic, is your cervical, where most of the movement occurs, and most of the movement occurs at the joints of the disc as well as the facets. So if you remember this much, you will be able to understand the aspects of your management. Early institution, see, natural healing support is there. The integrity of the stability of the spine depends upon the structure of the bone, the ligaments, as well as the muscle. This is basic in as you approach the problems. So conservative management and interventional management, along with some medications and other things. So if you look at it, it is this thing. So how to handle it? Some people have a severe pain. When you have a severe pain, especially you did mention about the pyogenic spondylitis. Yes, early diagnosis sometimes missed of pyogenic spondylitis, because you remember the lymph nodes are retroperitoneal, and part of it comes in because if you, I don't know, you go through some of the publications of the thing of the pyogenic spondylitis, it will give you certain clarity on how to diagnose it early clinically. So the pain and spasm of the muscles is less in lumbar spondylosis, whereas pyogenic is more. And there is one contradiction. You said antibiotic usage is not relevant. Actually, 26, there is a program online. I think COS, if you see that, I think ASSI is organizing a webinar. You look into that. I think in that there is a separate thing on the antibiotic role and this thing. And another thing is stem cell therapy. I think there were some studies at multicentric studies, especially Ganga has made, and there has been a publication in that. So different aspects of Modic thing. Modic thing, you look into that and it'll help you to identify. Definitely L45, L5S1 is the thing. Suppose the maximum amount of load in L5, 80% goes through the anterior aspect of the L5, and that is why the degeneration, height reduction, malalignment. I mean, these are all basic things which you have to learn. Malalignment and disruption, and ligaments doesn't sustain the stress, and bone gives way, and lysis and listhesis, and especially later facetal degeneration is all there. Whenever you look at it, you analyze the facets also. These two go hand in hand. As a spinal fellow, you must understand, make sure that the pain of the patient is understood, and the source of the pain of the patient, you must get at it, and that will help you to give a early restoration to his normal work. I think one of these days when I meet you in person, we'll further take it up for discussion. Thank you.
Thank you, sir. Thank you, sir.
Sriram, thanks for suggesting this topic, but I never heard of it. All new to me. Thanks for the contribution, Joe. Thank you.
No problem.
Thank you, sir.
Thank you. I'm leaving. I have to move. Thanks, David.
Thank you. Thank you. Thank you. Any more topics, Sriram?
No, sir. We have done.
So any questions from the fellows? Okay, Sham, you are there? Sriram, we can close the meeting. Okay.
Sure, sir.
Right.
Yes, sir.
Right.
Thank you.
Thank you. Thank you.
Shyam, do send me the link. Good night.
Sure, sure.
Whatever the topic will be, based on